Matthew Hart, another THCB Spotlight, and I'm delving into another large mental health online virtual company today. I have with me Robert Krayn, who's the CEO, and Georgia Caveras, who is the CMO, Chief Medical Officer of Talkiatry, which, as you may figure out, is a fancy combination of talking and psychiatry. Um, Hi, both of you. Nice to see you again. I saw you both at the Behavioral Health Tech Conference in Phoenix, and I think one of the things I wanted to do was spend a bit of time on two of the most interesting issues which came out of that conference. One is, what is the distinction amongst the many different and well-funded mental health companies of virtual online, and the other one is how is the online talk therapy and psychiatry business evolving, especially around the whole idea of how do you figure out where patients should go and who they should be matched with. So why don't we start real quick? Robert, give me the real brief background. Why did you do this? Why are you in this business? You were a Wall Street guy, but now you're not. So what happened first, and why are you in this business?
Yeah, of course. I don't know if I'd ever characterize myself as a Wall Street guy or a guy that just happened to work on Wall Street, but
You were an
I
investment banker, were you not?
yes, I was.
That counts. Don't.
Yeah, fair, fair,
You're either a Wall
fair.
Street guy or a tech bro, or you don't.
Yeah, okay.
Honestly.
All right, I don't know if I'm either. Yeah, but that's a good point. Yeah, I was working at an investment firm in 2016, and I had a home invasion in my apartment in New York City, middle of the night, a few days before Christmas. Ended up being the adult son of a neighbor across the hall. It was obviously a pretty traumatic experience, and a good friend of mine, his wife is a psychiatrist, and she suggested I go and speak to someone. I tried to find I wanted to see a doctor, so I looked for a psychiatrist. I couldn't find one. I emailed 20 people, and only one person responded, and they didn't take any insurance. So I had to go one level below ground to some office in Columbus Circle with 8 doorbells on the wall and tape underneath each one with a doctor's name written in marker. Long story short, didn't need medication. And walked out of the office and said, "Do I feel like I'm in good hands?" And the answer was a resounding no. And I just said, "I don't understand how this is how psychiatry really operated back then." Obviously, that was quite a long time ago, pre-pandemic. But that's really what got me interested in the space and trying to figure out a solution that made sense for everyone.
So, Georgia, where did you run into Robert, and how did you come from being a you're psychiatrist in kids, adolescents, and addiction, right? Certified
Yes,
in the three of
yes,
them.
yeah,
So, how did you
the
get right into
trifecta.
this?
So, that friend that Robert mentioned, his wife is a psychiatrist, and she and I were colleagues, what feels like a million years ago, in New York City. We worked together a long time ago. And when I heard, about Robert kind of thinking about the space, and, at first I was like, okay, well, why does this guy want to go into mental health? He's successful. He's, like you said, he was working in finance. Why this? You don't hear of people wanting to go into mental health necessarily. So I got to know him obviously, and you mentioned tech bro and finance bro. He is the opposite of that. He genuinely wanted to go into this because he really, felt that there was a need that needed to be filled. So my background is obviously in medicine, but in academia, I was working. I came back to New York after medical school and have always worked at different hospitals in New York. I was a fellowship director in child psychiatry, so I was in academia. I was in, teaching a lot, things like that. And what I found was that people that wanted to have private practices, that wanted to take insurance, they were having a really hard time with that model by themselves. So a lot of people, what they do is they work part-time at a hospital that would give them benefits so they could be an employee of a system and get all the things adults need, like paid time off and, 401k. But they also had on, as a second thing, they would do a private practice of their own. And it would be very hard for them to take insurance. A lot of them were cash pay businesses. And, it was just not a model that people really liked, having to split their time. Or if you go full on and open your own practice, then you're running your own small business, which a lot of people just aren't equipped to do. A lot of doctors, it's not what you learn in medical school. School, you learn a lot, but that's not one of them. So when it came to let's rethink the job of a psychiatrist and how a psychiatrist can work and have patients and see patients in this private practice model. I like to say he's the money, I'm the medicine, but that's how we got together basically. It's how do we create this model that will provide really great, high quality care and do it in a way that will benefit both patients and doctors. So here we are.
So, we'll talk about the how you deal with the patients in a second, but from the point of view of the psychiatrists, of the psychiatrists and the psychologists and the other counselors, the folks who work with you, what's the experience like, and why would they come work with Talkiatry rather than do that model, as you said before, of having a nice, working at Mount Sinai and then doing cash pay on the weekends?
Yeah. Well, some people they want a job. They want a job where they can really focus. When you do part-time, let's say, and you have, 2 days a week here, 3 days a week there, your patients are 5 days a week, right? So they might need something, and then you're kind of splitting your time and you're, constantly catching up. It can be very difficult for docs. Some people still like academia and they want to do that. And that's great. But a lot of docs just, that's what they want to do. They want to have a private practice. They want to be able to focus on it. But they also, like I said before, they want all the comforts that being employed by a system can provide. So our docs here, it can be predictable. Your schedule is predictable. Your benefits are predictable. Like all those things that you need are there. And a lot of docs really just like that model to be able to, and you can find it in any other practice, in any other specialty that existed, but in psychiatry it's really hard to figure out how to do the math. And that's what I'm really proud we're able to do.
Excellent. And just let me, before we talk about the patient side,
Mhm.
what's the current lineup between number of psychiatrists, psychologists?
Sure.
You have coaches as well. What else, who else
Yeah.
is in the team, as it were?
Yeah. So our clinical team is made up of psychiatrists and therapists. Our therapists are mid-level providers or master's level providers, I should say. So they're licensed social workers, mental health counselors, addiction counselors. They're all master's level, and we have about I'd say about 150 or so.
150
Yeah,
therapists, 450 psychiatrists.
yeah, and about 450 psychiatrists. Yeah.
So you're psychiatrist heavy, which implies obviously, some differences from some other systems, including obviously
Massive differences. Yeah.
Yeah.
drugs being a major one, among others. But we'll talk more about that. So that's interesting. So you've built a pretty big network relatively quickly. When did you actually found the company?
We saw our first patient in April of 2020.
Okay, so I mean, interesting time to start any kind of company. April 2020, 3 months into the 3 weeks.
Yeah, we were working on it well before that, and Georgia and I got together to start working on it in early 2019. But yeah, the launch date was always April 2020.
So let's flip to the patient experience. Now, you guys are in network with most of the major insurers, and you're like another doctor that somebody would go to that's covered by their insurance. So,
That's right.
And that's been my understanding. That's been mostly the way you've sold this, rather than going to employers or
Correct. We don't go directly to employers at all.
And so essentially you built this medical group. Let's talk a little about what was the idea, and as we mentioned, compared to some of the other services out there, which are well known at the talk spaces or others, you are psychiatry heavy rather than psychotherapy heavy. Obviously, psychiatrists talk to people as well. It's not it's not like there is no counseling going on in that. But why did you pick that model, and what kind of advantage do you think that gives you in the marketplace?
Yeah, I mean, listen, I think Talkiatry, is one of the highest quality providers in the space. We're one of the largest employers of psychiatrists in America. And so, when I take a step back, I most of those platforms you mentioned don't have any psychiatrists at all. So it's not even like heavy. It's like they don't have any psychiatrists on their platform, period. If they do medication management, they're using nurse practitioners. And I think it's just it's a different level of care. They can treat different patient populations, right? And so I think when you look at how it was created, I think number one, Talkiatry aims to be the best place in America for psychiatrists to work, full stop. You talked a little bit about it earlier, and Georgia did as well. But I mean, the reality is we've got the most academic resources here. We're ACCME accredited. We can actually issue continuing medical education credits to our doctors. We have a clinical leadership structure. It's not like they're just a pool of providers, with no resources and support. We pay at the top of the market for them, and we remove a lot of administrative burden so they can spend their time treating patients. So there's a lot of different things they can do, but they get all the flexibility of working in a private practice, hours, they get the highest compensation, but then they also have that academic rigor and that support system that they get in a hospital and health system, right? So I think first we always focused on how do we be the best place for psychiatrists to work in America. Second, we want to be the best partner for insurance companies. We've done that, if you will. We're a network, as you mentioned, nationwide with pretty much every major commercial insurance company in America, including Medicare and all the carve-outs. And then if we can do those two things really well, we become the best solution for patients. And we obviously are going to be talking about that in a bit. We have to be accessible to them. We have to make it easy, but we want them to get access to the best doctors in America that they otherwise couldn't, because 60% of counties in the US don't even have a single psychiatrist. And so when you think about why we focused on this model, we wanted to offer the best quality care possible. And the highest level of mental health care is done by a psychiatrist. And there's a massive shortage of them. There's only 45,000, 35 to 45,000, really depending on the metric that you look at, of psychiatrists in the United States. So they're the scarcest resource by far. And so while everyone else is focused on, in a large part, 1099 therapy or Uber for therapists, I think you could deliver better quality with a W-2 employed network, and specifically one that's physician led. And that's really kind of where we focus. But we also saw it as, there's a lot of people who are doing great work in 1099 therapy from an access standpoint. And we just saw that as, hey, there's a lot of those platforms doing well. I don't know that starting another one is going to help a tremendous amount of patients. But what we didn't see, and what we still don't see, to be totally honest with you, is someone who's building an employed, network of psychiatrists, which can, arguably, in the data that we've seen and the research that we've put out, provides really incredible care that's unparalleled, to be frank.
Okay, so let's talk about that. So that's great. You set up this big party. How do you get guests to come? Obviously, we've seen both in mental health, but also elsewhere, but certainly in mental health, a number of different players struggling either with the employer market or struggling with the insurance market to get recognized. Because great, you get covered by an insurance company, you're now one in a directory of a lot of people. There are still people calling around psychiatrists trying to find and like you were trying to find somebody in network. And
yeah, exactly. Yeah,
that problem hasn't gone away. We know that the ghost networks, etc., exist both in mental health and outside of mental health. How are you as Talkiatry going around saying, and we also know that there have been several other players, and there's been sort of stuff in the earnings reports about it from Teladoc and others about how much people are spending advertising direct to consumers. So how have you approached getting people to understand what Talkiatry is and how that even if you are covered now, they can start using you, and how do they find you?
Yeah, that's a great question. I think there's a handful of different channels that we operate in. One of them is what you've mentioned, so we'll touch on that first, which is direct to consumer marketing, right? And I think that Talkiatry uses one of our best assets there, and leads with it, which is doctors. Other people don't have them, right? So they're advertising online therapy. We don't advertise online therapy. So we're differentiated from that perspective, and we don't have as much of a direct competition because there's really not a ton of players in the space who focus on psychiatry. It might be psychiatry-like services with nurse practitioners. That's slightly different than what Talkiatry is doing today. And so of course, direct-to-consumer acquisition is a channel for us. We've also partnered with health systems to be a featured partner or preferred psychiatry partner for there. So they also have preferred therapy partners, to be clear, right? But we're generally the preferred psychiatry partner for a lot of the health insurers that we work with. And then we also have health system partnerships, right? So Talkiatry announced, a relationship with HCA nationwide. We've recreated that with a bunch of other health systems as well. It's a strong vertical for us, but we have a lot of, local or nationwide resources with other provider groups, health systems, for example. Even some that are in the mental health space, like Charlie Health, which you may or may not have heard of, but they do intensive outpatient care virtually. And so we've partnered with them, for example, to refer patients who need a higher level of care that we can't treat, but also patients that are doing a step down program, right? And so we have other higher levels of care that we work with, as well as primary care and specialty care providers.
And roughly for those different channels, how would you say patients get to you? Do you have a percentage breakout?
Not that we've talked about publicly.
Okay. All right. Well, I'll try to guess, and I'll try to figure out how much you guys are spending on DTC by looking at the next Teladoc Health report. All right. Let's talk a bit about what now they found you. Now they've found you. Now they're going in. There's this idea about what happens next, and there's a lot more discussion now than there was a few years back about, okay, how do I make sure someone's getting to the right place and the right treatment earlier? So you're going to show us, Robert, your approach to that. So. Yep. I show up at Talkiatry's website by hook or by crook, and show me a bit about what happens next.
Yeah, so you go to Talkiatry's website. You click Get Started, and so when you click Get Started, you'll be brought to a page that looks like this, which just kind of gives you a little bit of heads up of what to expect here. We're going to do an insurance and location check. We want to make sure that we're matching you with a doctor who can actually treat you, right? Medicine is still done on a state-by-state basis, governed by state laws, so that's super important. But also, insurance is still difficult to navigate, right? You might have something that says a brand name on your card and then realize that actually the mental health services are covered by someone else. And so that's also a big barrier to care, which is it actually covered? Is it not? What does that look like? And what we don't want to do is have a patient come to Talkiatry, think they're covered, and then find out that they're not once they finally found a psychiatrist. So we're going to spend a lot of time going through doing the insurance check. We've made it very, very easy. We've got great partners. You can just put in your name, your member ID number, and then we'll return what that looks like. We're going to skip that section for this and the personal details just for the sake of time here. But we after that, we'll go into the clinical questions. That's where we're going to start here, and then we'll actually be able to book an appointment with a doctor at Talkiatry. And then you get to this page, which we want to collect information about why you think you're seeking care. We're obviously going to give you a full diagnosis or preliminary diagnosis at Talkiatry, but we want to know, you may already have gotten a diagnosis or have an idea. So we're going to select, anxiety here as the reason. We also want to make sure that we're checking secondary conditions. We do match based on multiple different conditions here. So we do have doctors who, can treat comorbid substance use disorders or eating disorders. We're going to say none of that applies here, but these things are important to get to make sure that we can treat all of the conditions. We also want to get an understanding if you're looking for anyone specific. If you're planning to get pregnant, for example, we have doctors who are specialized in treating that. There are nuances there. We'll say none of those apply for this case. Then we're going to ask you a few questions about your mental health, right? In the past 6 months, were you looking to stay overnight in the hospital? We're going to say no here, but these things are important to just understanding the level of care that we may or may not be treating. And then we also want to know if someone's at risk, for harming themselves immediately, and we want to make sure we get them care. And setting an appointment, obviously, for even if it was for the next couple of days, may not be the right place to do it. We want to collect some information about your habits with drinking. We're going to say I don't drink here. We're going to do the same thing about drug use. We're going to say never. Again, this is just making sure if we're matching based on substance use disorder or other types of things. If they're already taking medication, we want to know, are they open to taking medication? They're meeting with psychiatrists, of course. It's one of the tools in their tool belt. And then, of course, we want to make sure that
actually on that one, what is it, if you say why we ask, what does it say there? So you feel so that's just saying that we actually we use it. All right. Fair enough.
Yep.
Okay. Makes sense.
We'll collect pharmacy information usually at the time of visit, but we want to make sure we have a pharmacy on file so we can easily send it complete refills, things like that for you. I'll put in some fake information here, but we want to make sure that we've got good emergency, contacts. So we can reach out in case anything happens. And we do actually have a protocol that we actually can connect to 911 in your local area, even if you're not, I don't know if you know, but if you call 911, it goes to your 911, not the person who you're calling on behalf of. And so we do have different pieces of software to do that. And we're going to say we don't already have an initial appointment because we want to get one ideally. You'll be able to go through and review personal information to make sure it's all right. You'll have the option of changing certain things. And we're going to use that information. We're going to match you based on location, condition, age. There's obviously a lot of other things, that we're matching on. And it'll go through, obviously we mentioned we have hundreds of doctors, right? So this is going to pull up and say, hey, what do they specialize in, for example? And you can view their bio, right? And so you can look here and say, what does this person specialize in? What's their bio? You can go in and say, oh yeah, I'd like the 19th. I like, a morning spot, for example. I'm going to confirm an appointment. And then it'll go ahead and book it on the back end for you. Make sure the spot's still available, confirm it, appointment's booked. Of course, if there's some additional things we want to do, if you want to upload a picture of your driver's license, for example, all of those things are available to do here. You might want to upload previous medical records. You have the option of doing that. You can call us if you want to talk to us on the phone about changing an appointment or changing a provider or anything along that line. And you can contact our support team again if there's something specific, and then you're done. And you'll get an email with a link. And when you click it, the first person you talk to is in this case it will be Dr. Josephs.
You probably better tell Dr. Joseph not to have this particular appointment, but I get the idea. Now,
I'm going to make sure my team cancels that.
Right. In that particular one, so part of the issue here on his access. In that particular one, looked like he wasn't available for a couple of weeks. Do
Well, he
you?
had a sooner appointment. I just didn't select it.
Uh,
But yeah, but the one I selected was in 2 weeks. But yeah, there was an earlier one.
what's the average time to availability for an appointment? And then
Five
how? Sorry,
5 days.
5 days. And then
Yep.
on the flip side, maybe this is a question for you, Georgia. Obviously, you're getting as you sign on your psychiatrist, you're looking at you getting information about that, especially, and see some of that is available, and you could see that on the screen for the for the consumer, for the patient there. But I mean, when it gets down to that point of, so that was a relatively simple case, right? That was anxiety, which is pretty well known. Most psychiatrists can deal with that. It's not a big deal. Had you gone down the more complex path, what does the matching look like on the back end? How much of that is automated? How much do I always come up with the right one? And how often do you end up with somebody who is not quite right and have to figure out if there's a different person within the network who's better for them?
I mean, we have such a diversified provider group that unless it's something that Talkiatry doesn't treat. For example, we don't treat primary psychotic disorder, something where you may need an injectable antipsychotic, right? That's just not, we can't do it because we're virtual. So unless it's something like that, for the most part, we have such a diverse group. We have child psychiatrists, geriatric psychiatrists, people that specialize in psychiatry for those who have serious medical illnesses and comorbidities, addiction psychiatrists. We have so many with such varying specialties that honestly, it's very rare for you to be within the scope of practice of psychiatry and not have a match within a week or two, like Robert said. I mean, some of our Robert's in New York. We were looking in New York. New York is our largest market. This is where we started, so it is a large market for psychiatrists. In states where we have fewer doctors, maybe the wait time might be on the longer end rather than the shorter end. But for the most part, it's very rare that you're within the scope of practice and not be able to find a psychiatrist.
All right. And then what happens once someone's in the process with the psychiatrist, especially if either the psychiatrist doesn't think it's right for them or the patient isn't quite happy with the psychiatrist? Is there another system like this, or is there a way that you have?
Yeah.
How do you manage that?
Yeah, there is. So if after the first meeting, I mean, we worked really hard to try to make it so that the first meeting is with the doctor that you will have long term. You don't want to tell your story that many times, right? If though, I mean, things happen, things don't work out. Sometimes there's an X factor that just doesn't click for both sides. If the doctor and the patient agree that it'd be better to re-engage with a different provider, we have a process internally where we will rematch you with a different doctor, and that way you can resume your journey with somebody else that will still meet your needs, but is different for whatever reason.
We have automated tooling that'll put you through the rematching process, and the doctor can say, oh, okay, you might have selected anxiety, but there's some specifics here that's wrong, and I'm going to redo it, and I'm going to put you back into the matching, if you will, and then it's automated, and you'll get a new link to schedule something. But it's driven by the providers on our end.
And remember, when somebody has selected from that list of why are you here, people are taking a guess sometimes. They think they have X, but they might have Y. So once they actually meet with the doctor and actually talk things through, you may find that there's something else going on where you think that you'd be better served by a different doctor, and that's fine. No harm, no foul. We can rematch you.
Right. So two questions that you've touched on. One is the issue, and I don't know where we're going to be with this in terms of where there are fewer psychiatrists in general. So talking about rural areas and elsewhere and other states, you have to deal with that problem. Have you had to do specific things around that? I know there's an interstate compact for some of the smaller states and the rest of it, but over the state lines issue, and where do you think we are in terms of fixing that, or is that never going to be fixed?
I think I mean, that's to fix that, you would really need to create a kind of a national driver's license, right? That's back in the day before the driver's license was created. It was state by state. Obviously, it doesn't work, right? And so, the federal government took it over. So I'd say in medicine, though, that's
Hang on, I still have a California driver's license.
Yes, but it works in other states, right?
Yes.
You don't need to get a new driver's license. So, but unfortunately in medicine, that's not how it works. You're licensed in New York, and for doctors specifically, their training is the same no matter where they are in the country, right? It's just an administrative process. But unfortunately, right now, you do have to get a new medical license in each state where the patients you're treating are located. And so, I think most states have rolled those back. There was some, some breaks due to COVID on that front from a regulatory standpoint on a state-by-state basis, but those by and far have been rolled back. And so the original law is back in effect in each state, which is basically you have to have a medical license in each state to treat patients. And so we've always followed that. And so we do have our own licensing team at Talkiatry, so we will help get additional licenses. We don't want to burden doctors because the CME requirements are still significant for each state to maintain that license. So typically a Talkiatry provider will have, 3, 4 licenses, perhaps typically in surrounding states. If in New York's a good example. You're in New York, New Jersey, Pennsylvania, maybe Connecticut, in California. We've got people who've got California and Texas, or California and Nevada, or something along those lines. And so it's still something that we have to overcome. I think telemedicine can go a really, really long way because those rural areas, there's still psychiatrists in the state. They just don't live in those counties. But with telemedicine, we now have access to everyone in the state, if you will, for any doctor who's got a license in that state. So in a place like Texas, that goes a really long way because the population is so dispersed, and you could live in Dallas, but that doesn't help people in Houston or San Antonio necessarily.
No, so I mean, I think that's an area. I know there's a current lawsuit between some folks in New Jersey having a go at New Jersey, which has got particularly vicious licensing.
I did hear about that. Yeah, with the licensing issue of yep.
We'll see how it rolls out, but I mean, so what you're basically saying is it's a complication, but you've kind of figured your way around it. Okay, the second question I wanted to bring in, and you mentioned it slightly, Jordan, when you're talking about people who needed injections and psychotics, is what is that relationship between the physical and the virtual, right? So, do you think both that it's how you manage that? I don't know what proportion of your patients would need to go on to some kind of physical care, whether it's inpatient or, intensive outpatient or whatever, where it's in a physical setting. And then the other question is, does that lead you to naturally at some point have to think about whether Talkiatry has to get in that game as well?
So I don't know. I wouldn't be able to tell you. I don't know if Robert knows, but I wouldn't be able to tell you the percentage of people. I mean, the thing is, as telemedicine has evolved, now there is virtual IOP. Now there is virtual PHP.
Right.
Inpatient, obviously, it's different. That's physically different. But there are higher, more intensive levels of care, if you will, in the virtual space. And we do partner with some of them actually in order to be able to keep people, keep people's treatment seamless, so that they can go from higher to lower levels of care. When it comes to psychiatry via telemedicine, I think it's not that one modality is better than the other, in person versus virtual. It's a matter of it's different, right? It's a different experience that you have. So right now, if you're in your home, for example, Matthew, right now, I could, if I needed to speak to your partner or to your caregiver, it's much, much easier to do that because they're probably in the other room. Right. So that makes it a lot easier than if you were in my office and then I have to call them. Right. And God knows if I could ever reach them, right? Because telephone, it can be unreliable. So there's different things. And obviously, if you were in person, there's different things that I could see about you physically that I wouldn't be able necessarily to see via tele. So there is a difference, but I wouldn't say that it's necessarily one is superior to the other. Some people do better in person. Some people do better virtual. I mean, I think that the point for me is, if it's going to get someone to see a psychiatrist, already there's so many barriers to people seeking mental health care. There's so many. So if I can get them at least to engage this way first, if that's what is going to help them help get more people to a mental health professional, then let's do it. And then after you meet with someone, then we can say, you know what, this one might be better for you. Maybe there is somebody that does need more intensive treatment, right? In an in-person setting, somebody that may need a residential treatment, for example, for a very severe eating disorder, for example, where they're medically unstable and you need to refer them to somewhere where they can see them in person. And that's, at least though they've spoken to someone, otherwise they'd be home and they would never see anyone. So I think that this is a great way to just get people engaged in the process. And then we can help them. They might not be ready yet, but at least you can help them to get to that point where if they need to move on to a different level of care, you can help get them there. So for us right now, listen, there's so many things within psychiatry. I always use the example of, if you go to a dinner party and meet someone who says they're a doctor, you immediately ask what kind of doctor they are, because medicine, obviously there's a lot of variety. That applies to psychiatry. We started when we started talking, I mentioned I'm a child psychiatrist who specializes in addiction. That's what I liked. I was treating adolescents and young adults with addiction problems. That was my specialty. I'm not a good geriatric psychiatrist. I'm not trained in it. So sending me someone that needs a geriatric psychiatrist, I can't really help you very much. I'll try my best, but that's not my specialty. So within psychiatry, talkiatry, we are focused on a particular thing. This is where Robert and I started, right? We started with this. Does that mean that this is where we're going to stay forever? No, of course, there's so many areas of psychiatry and there's so much work, there's endless work in mental health that people need to focus on. Thankfully, more and more people are focusing on it. So right now, this is what we're doing. In the future, though, I think that there's lots of things that Robert and I would both love to see and would love to go into. But right now, this is where we're really focusing our work.
All right, a couple of things to end on. The first one is that we talked a bit about the intake process and matching people and the rest of it. Traditionally in psychiatry, we haven't really had very good measures about outcomes and who's doing a good job and who's not doing a good job. And earlier on, Robert was saying, well, we're great because there are so many psychiatrists and psychiatrist-led care. I assume that is more expensive in general than having therapist-led care. So when you go to have the conversation with those insurers as to why psychiatry and why talkiatry, I managed to miss an L somewhere in the middle of that. What are the kind of ways that you're capturing outcomes measures and reporting that?
Yeah, of course. That's a great question. I think, of course, we use evidence-based scales, PHQ-8s, GAD-7s, things like that. For example, we put out a peer-reviewed study that was published in JMIR at the end of last year, where we looked at 1,800 patients that came to talkiatry with PHQ-8 or GAD-7 scores that were 15 or higher, and that's severe anxiety or depression. Arguably, you could be going into an intensive outpatient program, which is very, very expensive at that point. You're talking hundreds and hundreds of dollars a day for 10 weeks sometimes. We measured those patients, or we monitored them over a 15-week period. It's not when their care ended, it's just when the measurement period ended. Over the course of that 15 weeks, patients had an average of 5 appointments with a talkiatry psychiatrist. And at the end of those 5 visits, about 30% of those patients were in clinical remission. About 65% no longer had clinically significant symptoms, and about 80% had a greater than 50% reduction in their symptoms. And so after 5 visits, their PHQ-8 and GAD-7 score was an 8. Those are results that you would hope to get after completing successfully an intensive outpatient program sometimes, right? So those are pretty incredible results. So it's a big sample size. They were very statistically relevant, for example. And so you compare that to some of the costs of higher level care, and it doesn't look very expensive anymore. It looks actually incredibly cheap. And so when you look at that, also we've done it on a matched cohort basis with some of our insurance partners, where we say, hey, take a look at all of your patients with talkiatry and build a identical patient population, same ages, same gender, same geographic area, same primary physical conditions and behavioral health conditions, like build an exact patient population. The only difference is that the matched cohort is not being treated for their behavioral health care by talkiatry. They're being treated by anybody else in your behavioral health network. Apples to apples, treating the same patient population. Does talkiatry do better or worse than the rest of your behavioral health network? Period. Are those patients better off at talkiatry or somewhere else? And we had them measure 3 things: inpatient hospitalization rate, ER visit rate, and those things are not just for behavioral health conditions, just period. So physical conditions or everything's in those admits. And then total cost of care, physical spend, behavioral health spend, medication spend. Where do we stack up? We did that study with a large national payer who unfortunately I can't name because we had to make the choice of, are we naming the payer or the results? Obviously, we're going to choose the results. And so, our patient population had, I believe it was a 68% lower inpatient hospitalization rate, a 35% lower ER visit rate, and we reduced the total cost of care for that patient population by $700 per member per month. We saved that payer. That's an astronomical number that I haven't even seen, right? So when you talk about just, does it make sense financially? The answer is it makes all the sense in the world financially to send these patients to talkiatry versus anywhere else.
Fantastic. All right. Last couple of questions to go. Last couple of questions towards the end. First off, what's the system, sort of the technology system that you set your how when I show up as a psychiatrist, I'm new to psychiatry. What am I getting from you? And what you talked about the benefits of not being an employee. What do I get? And what's the setup I have? Do you have your own system? Do you use somebody else's? What's the technology?
Yeah, I mean, the short of it is you get everything. You don't have to bring anything to the table. We provide everything, the hardware and the software, for example. On the software side, there's things that we built custom to manage their practice population, to, Georgia said, to reassign patients, all of those things internally we built on top of things. But you'll get the EMR, you'll get everything you need for telemedicine. You get our entire platform, which does licensing, credentialing, revenue cycle management. I mean, again, you're a true employee working at basically one of the largest mental health systems in America.
And do you have a EMR? Do you have one standard EMR? Or do you have multiple?
We have one EMR that we built on top of and away from, but we use eClinicalWorks as our core EHR for documentation purposes.
Okay. And then final question. I think you raised 130 odd million earlier right at the start of this
That's right.
year. And
That's right.
how much in total so far?
About 245 million.
All right. You've got a number of competitors. Some of them raised a lot more than that. There's obviously a kind of I wouldn't say a war because you're too gentlemanly you're all too, we're professional and gentlemanly, we do that. But there's clearly a struggle for market share in these large online virtual behavioral health companies. As of yet, with the exception obviously of Talkspace and the BetterHelp within Teladoc, you haven't seen any of these companies go public, but some of them have been around a while. You're relatively new in the space. Give me a sense for what your thought is to how many of these companies, how many of these companies are not necessarily can survive, but can thrive going forwards, and how occupied is the space? I mean, are we at the point now where there are enough online behavioral health companies, or is it the fact that we seem to have, the growth in the demand is so big and the problems are so diverse that we can expect to see, a healthy market with multiple companies surviving? Give me a flavor of how you think about it.
Yeah, I mean, I think you can expect to see a healthy market with multiple companies surviving in a really meaningful way. I mean, the truth of the matter is that 60% of adults with a mental illness in America still go untreated in every single year. So we don't have enough providers. We need to make more in a significant way. I think there's plenty of patients to treat in need. And I don't think we're at risk of that in a meaningful way in terms of being able to treat those patients. Now, I think that there's a lot of different segments of behavioral health care, right? There's people who focus on therapy, there's people who focus on intensive outpatient care, there's people who focus like Talkiatry on psychiatrists. Eating disorders, geriatric care, right? There's a ton. And then on top of that, you've got even more differentiation, right? Because the people that you're talking about who've raised a lot and have been around for a long time, they mostly focus on the employer market. And so I would say it's a very different model than what Talkiatry is doing. They're not typically employing doctors, and they're not typically providing ongoing care, if you will. They're more of an employee assistance program. And so I'd say that, if EAPs have existed for decades and decades, right? I think the largest EAP in America, in the world, is a company called ComPsych, which has been around for probably 30 years, if not longer, right? And so, I would say that clearly the market can support, a really large number of very largely sized players in the space, especially because they all have differentiation. I wouldn't know, to be honest with you, I wouldn't really consider any of them direct competitors, to just be totally frank. Like we don't compete with the APs. We don't sell them to employers. They don't hire doctors. So how are we directly competing with them? In what sense, right? There's people who are hiring 1099 therapists. They're selling software so the therapist can operate their private practice. That's great. We don't let people operate. People come to Talkiatry, to work here as an employee, rather than powering their own private practice. Now we give the autonomy of having a private practice, but there's a lot of big differences there. We also don't have a massive, we're not dominant on the therapy side, if you will. We're psychiatry led, and so we look at a lot of these folks as one, friends, and anyone who can help patients is great in our book, and two, partners. We mentioned some of them in the space of behavioral healthcare that we partner with to send patients, for referrals, community referrals, if you will. We can't treat everyone, and neither can they. Everyone's got some nuances in what they specialize in, and we've been great in kind of building those partnerships. We've got patients who need therapy. They've got patients who need psychiatric care, and again, I think there's room for some really scaled large players, and I think there's a tremendous amount of growth there. I think the growth in prevalence of mental illness in America has increased double digits in the last decade, a really significant growth rate, which is far outpacing the supply growth of behavioral health providers.
I don't know if we blame iPhones, TikTok, or the pandemic, but something happened.
You can definitely add that in. It definitely didn't help. I'd say that.
All right, my last question is for you, Georgia. We, as we met at Behavioral Health Tech, and this came up all the time there and comes up all the time.
Mhm.
Robert just mentioned it. We have 60% of people untreated. You know, we have a huge,
Yeah.
huge growth in demand, and we have this clever thing called AI, which is supposedly, going to be able to do a lot of what psychiatrists, therapists, and others do. God knows
Yeah.
what else in every other job in
Yeah.
America, probably including podcast host and interviewer. In fact, I know it can do podcast host. Don't know why I'm still doing this, but give as a psychiatrist,
Uh-huh.
what are you looking for? What do you hope AI will do to help you and the people who work at Talkiatry? And what do you think the most likely parts of AI that might get rolled out to support your organization are going to be?
Yeah, I think that, the first thing, and I think the most obvious thing is the administrative burden that comes with all physicians, not just psychiatrists. I mean, there's a well-known study from a few years back now about family practitioners, and when you look at the how much work they actually have to do, they need to work, what is it, 26, 27 hours a day, which is, I mean, it's absurd, right? I mean, the whole thing was absurd. So I think that there's just a natural slot for that, where if you can help with just the messaging, for example. I mean, with the rise of EMRs, your ability to contact your doctor 24/7, right, is great. If you remember something at 3 a.m., you can send a message. So that, but somebody has to read them on the other end, right? So those kinds of things, I think, are natural ways where AI can immediately be useful. Documentation, I think that people forget about psychiatrists and therapies that we do a tremendous amount of writing. It's not just about putting blood levels in. You literally tell a story every time that you write about your patient. You tell a story. So I think that's just a natural first space. But there's some very, very interesting AI assisted therapies, very interesting uh, ideas, and I'm going to call them ideas right now because I don't think anyone knows exactly what makes the most sense about how therapy can be. I'm not going to say replaced, because I think that the human to human interaction in therapy is something that cannot be, that's sometimes underestimated, but I don't think can be overestimated. But I think that there is definitely a place for assisted therapy, for kind of when you're not with your therapist, what can you be doing in between your sessions? Therapy comes with homework. Therapy is work. It's a lot more work for the patient than it is for the therapist, honestly. And so when you're not in front of your therapist, there are things that you're doing in between that are going to help you the next time you see your therapist. I think there are just natural ways that you can incorporate AI in order to facilitate that relationship and your treatment. I think we're still ways away from saying that, my job and your job will be completely replaced. I'm hoping that that's not the case, and I genuinely don't think that there's going to come a time where you never have to see another human, at least not in my lifetime. But I think there's just a lot of opportunity to make the process and make the your entire mental health journey better for you and on the doctor side, to make it so that you can provide better and more efficient treatment for your patients as well. Because if we can't multiply the number of doctors, you can't just make more doctors faster. It takes years to make a psychiatrist. So why not enable them to multiply their time, right? Make them able to just see patients and be able to treat them more efficiently. I think that's where the next logical step would be.
Yeah, I think the whole idea of building more and more tools to help people, in between the gaps in visits, as well as obviously to support the doctors with ambient AI and all that kind of good stuff.
Yeah, yeah.
That to me is very interesting, and I think that'll be something that I assume as you look at this and figure out how do you multiply the time of your doctors and multiply the impact on your patients that you'll be doing, and you can come back and show that to me when you've figured out what that is. All
I
right.
hope so.
I've been talking with Robert Krayn and Georgia Caveras. They are respectively the CEO and Chief Medical Officer of Talkiatry. Thanks for your time.
Thank you,
Thank you.
Matthew.